Good morning, everyone. For today's clinical meet, I'll be presenting on behalf of Medicine 1. The title for my presentation is The Lazy Gut. Miss D, she's a 28-year-old lady from West Bengal. She had presented to us with complaints of vomiting, cramping type of abdominal pain for 6 months, along with loss of weight for 6 months. So she had around 10 to 12 episodes of non-bilious, non-bloodstained vomitus, and it's usually present after food intake, usually after 30 minutes. And it's associated with nausea, and the contents are mainly food particles. Although there was no bloodstain, she had one episode of small bloodstain in the past. Abdominal pain, wise, she had diffuse abdominal pain, but was more present in the epigastric region, and was a cramping type of abdominal pain, which was exacerbated by food intake. There was no radiation to the back, and she had lost around 20 kgs of weight over the last 6 months. There was no history of, she had not noticed any masses in the abdomen. There was no history of any jaundice, loose stools, no features of any autoimmune features like oral ulcers, photosensitivities, dry mouth, dry eyes, and no history of any fever associated with the loss of weight. So background history, she was diagnosed with diabetes at the age of 16 years. The index presentation was only generalized fatigue and tiredness. So we don't have an index HbA1c, but she was started on insulin and she's been non-compliant. So her glycemic control is poor. And 1 year ago outside, she also had a DKA. 2 months before presenting to us, she was admitted in an outside hospital for vomiting, and she was treated for a pyelonephritis. They had done abdominal imaging with a cross-sectional, a CT scan. None of them showed any obstruction to the GI system. And upper GI scopy was done outside, which showed pangastritis. So our examination, she was a thinly built lady with a BMI of 16.2. She had pallor. The rest of the examination was not significant. And we also looked for a postural drop in BP, considering she has a long-standing diabetes, and there was none. So now we were wondering what was causing the vomiting in a diabetic patient. So our differentials were one, a diabetic gastroparesis, because she was a long-standing case of diabetes of more than 10 years. We also want to look at her medication to see if anything was causing vomiting. We considered psychogenic vomiting or any, in a diabetic, we also have to rule out any esophageal candidiasis, whether there was a chronic pancreatitis or any peptic ulcer disease or GERD, or if there's any intra-abdominal infections like a pyelonephritis causing vomiting. DKA can also cause vomiting, but not for a chronic, not in a chronic setting. So with these differentials, we went ahead and did some investigations. We found out that she had a normocytic normochromic anemia. Her proteins and albumin was low. There was also asymptomatic pyuria. Her HbA1c is 8.7, which shows poor glycemic control. So because of the strong suspicion of a diabetic gastroparesis, we went ahead and did a scintigraphic gastric emptying time. So what we found out that at the 4 hours, there was delayed, and it was grade 1. Which means that there was 17% of the food still retained in the stomach at the end of 4 hours. We also did an upper GI scopy, which showed gastric erythema and edema. So now what was the cause of vomiting in our patient? We narrowed it down to diabetic gastroparesis, as well as she had gastric erythema. So for my discussion, I'll be talking about gastroparesis and how to manage in a diabetic. So what is gastroparesis? It is a syndrome of objectively delayed gastric emptying. So we should have an objective way to show that there is delayed gastric emptying in the absence of a mechanical obstruction. So the prevalence of gastroparesis in type 1 diabetes is higher than type 2. It's 4.8 in a type 1 and only 1% in type 2. And even in hospital-based settings, it is shown to be higher in type 1 diabetes. But because we see more type 2 diabetic patients, we see more patients with type 2 who have gastroparesis. And it is usually seen after 5 to 10 years of the onset of diabetes, and it's more prevalent in women at the ratio 4:1. And it is associated with microvascular complications of diabetes. So if they have retinopathy, neuropathy, or nephropathy, and also if they have poor glycemic control at the beginning of the disease, then they tend to get gastroparesis. So there are many mechanisms. I'd just like to concentrate on 3. One is there is loss of the pacemaker cells of the gut. So that is the interstitial cells of Cajal. There is smooth muscle atrophy, and also there is loss of nitric oxide. So all of this causes decreased gastric emptying. They can present with a variety of symptoms like nausea, vomiting, satiety, early satiety, bloating. So there is something called as the gastroparesis cardinal symptom index. So they have grouped the symptoms into 3 parts. One is nausea, vomiting, one is fullness and early satiety, and bloating. So they have a total of 9 questions that are graded from 0 to 5. So a total score of 45, and higher the score means higher the severity of the gastroparesis. So again, for diagnosis, there are many methods to diagnose, but the gold standard is scintigraphic gastric emptying time, and especially at 4 hours. So now how do we treat it? So the first line of treatment is mainly managing the nutrition, giving them prokinetics and antiemetics. But for refractory cases, we also have something called as gastric electrical stimulation, Botox injection, gastric myotomy, as well as surgical pyloroplasty. So for us, I'll just cover a little bit about nutrition and prokinetics. So how do we manage nutrition in a patient with mild gastroparesis? We need to give them small quantities of fluid, but more frequent. And they should have high calories, but low fat and low fiber. And if it's very severe, then we can also give them feeding jejunostomy. So prokinetics, the FDA-approved drug is metoclopramide. But the problem is because it acts in the central system also, there are a lot of CNS side effects. So usually they have suggested to give prokinetics for a duration of 3 months, and it's as much as possible, we need to give them drug holidays or reduce the dose. There is also an antibiotic called erythromycin. Basically, it simulates motilin. So that causes fundic and antral contraction, and that's how it helps with the gastric emptying. There are also therapies which target the 5-HT4 receptors, the D2, D3 receptors like etopride, mosapride, and NK1 receptor antagonists. So which is better to give, metoclopramide or domperidone? So there was a double-blinded study which was done where they had taken 93 patients and patients with 3 months history of gastroparesis. So in one group, they gave domperidone, and the other group, they gave metoclopramide, and they looked at 2 outcomes. One is the efficacy, whether there was any improvement in decreasing the gastroparesis symptoms. Second one was side effects in the CNS side effects. So what they found out was there's no significant difference between the efficacies of both the groups, but the CNS side effects were more higher in metoclopramide group, like somnolence, akathisia. This is because domperidone is a peripherally acting thing, so it's better. Now, coming to prognosis, could not really find any study about the prognosis, but what they have mentioned is that once a patient develops diabetic gastroparesis, even it is usually permanent. We cannot cure it. And even if we do achieve glycemic control, the symptoms never really disappear. So now coming to our patient, so she was mainly admitted for glycemic control and for managing the vomiting. So she was, we had adjusted her insulin doses and achieved glycemic control. We had advised her nutritional changes, and she was also started on prokinetics. We had given her metoclopramide and etopride and also amitriptyline at the time of discharge. So she had come to our OPD, and she has said that there is significant improvement in the vomiting. So the frequency of 10 to 12 episodes has come to 3 days. 3 episodes per day, but has not completely disappeared. So take-home points: how to diagnose a gastric paresis. The gold standard is a scintigraphic gastric emptying time. We need to look for other causes of vomiting also. And the first line is always nutritional, prokinetics, and glycemic control. Only in refractory cases, we go for surgical pyloroplasty and the rest.
Good presentation. What is the logic behind the low fiber diet?
So low fiber diet is supposed, because it's supposed to absorb water, it's like an osmotic thing. So it causes early satiety and vomiting.
Any other questions? Next, we'll have Brightest from Medicine